All right, let's jump right into clinical metabolism and electrolyte homeostasis. This is a high-yield active recall sprint, so we're going fast. Starting with question 61. Considering a basal energy expenditure of 2,000 kilocalories per day, what will be the energy requirements in a patient with multi-organ failure or sepsis? Are we looking at A, 1,000, B, 2,000, C, 3,000, D, 3,500, or E, 4,000 kilocalories per day? And the answer is C, 3,000 kilocalories a day. Here's why. Systemic sepsis and multi-organ dysfunction syndrome literally send the body into an intense neuroendocrine stress response. It bumps up the basal metabolic rate by about 50%. So half of our 2,000 baseline is 1,000. Add that right back to the baseline and boom, your total adjusted target is 3,000. It's fascinating how these metabolic surges scale, right? Like an uncomplicated surgery is just a tiny 10% bump. Trauma sits around 15 to 30%, but extensive, severe burns? No way. Those can cause a massive 100% to 200% increase over baseline. Moving right along, question 64. A moderate increase in basal metabolic rate or resting energy expenditure occurs in which of the following? A, major burns, B, sepsis, C, peritonitis, D, moderate exercise, or E, starvation.
It's D, moderate exercise. You see, exercise causes this really predictable, transient, and, well, moderate increase in metabolic demand. It's totally different from the severe, prolonged hypermetabolic states we see with burns, sepsis, or peritonitis. And here's a fantastic exam pearl for you. During prolonged starvation, your body actually adapts to conserve energy. It intentionally drops its baseline basal metabolic rate by roughly 10% to 15%.
Okay, let's tackle question 62. What is the amount of calories required in a patient with severe malnutrition? Looking at the weight-based options, is it A, 25, B, 30, C, 50, D, 100 kilocalories per day, or E, none of the above? The target here is roughly 30 kilocalories per kilogram per day. When you're dealing with severely malnourished patients, you absolutely must start them cautiously at these baseline energy requirements, somewhere between 25 and 30 kilocalories per kilogram per day. Why so careful? Because we are tiptoeing around the fatal refeeding syndrome. It's a real danger. Only once metabolic stability is fully locked in can we safely advance that target to 35 kilocalories per kilogram per day to actually start restoring their lean body mass. Let's apply that to a clinical scenario. Question 63. A 55-year-old man with carcinoma of the esophagus is admitted with severe malnutrition. Nutritional support needs to be initiated. What should be his initial caloric intake? The options range from A, 1 kilocalorie per kilogram of body weight per day, all the way up to E, 100. Just like we just talked about, the answer is D, 30 kilocalories per kilogram of body weight per day. In a cachectic oncology patient, we really have to balance baseline energy without completely overwhelming their intracellular pathways. If you aggressively overfeed on day 1, you're looking at severe fluid shifts and life-threatening intracellular electrolyte depletion. Now, regarding substrate ratios, as hypermetabolic stress escalates from normal to severe, we have to adjust that non-protein calorie to nitrogen ratio. It drops from 150 to 1 down to 90 to 100 to 1 just to adequately support cellular repair. Next up, question 67. Which of the following is seen in a patient having prolonged or severe malnutrition? A, increased albumin levels. B, increased prealbumin levels. C, increased skin hypersensitivity. D, abnormalities in lymphocytes, or E, none of the above? The answer is D, abnormalities in lymphocytes. Basically, severe starvation effectively paralyzes the immune system. Now, their total white blood cell count might actually look perfectly normal in a lab report, but the functional T lymphocyte production drops significantly, totally depleting those crucial CD4 positive helper T cells. Malnutrition blunts cell-mediated immunity, and that causes anergia, which is just a fancy way of saying a loss of skin hypersensitivity, and it impairs phagocytosis. Plus, the hepatic synthesis of albumin and prealbumin drops sharply, which makes options A and B completely incorrect. All right, pivoting to nutrition delivery, question 66. In which of the following conditions is enteral nutrition contraindicated and total parenteral nutrition considered? A, severe malnutrition. B, acute pancreatitis. C, gastric carcinoma. D, esophageal carcinoma. Or E, high-output enterocutaneous fistula. You guessed it, it's E, high-output enterocutaneous fistula. Think about it. Any fistula leaking more than 500 milliliters of intestinal contents a day is an absolute contraindication to gut feeding. If you deliver nutrients directly into the gut lumen, you just stimulate more secretions. That increases the volume leaking right through the tract and completely prevents it from closing spontaneously. These patients absolutely must have their bowel put at rest with TPN. Other absolute contraindications would be things like ileus, ischemia, and shock. But keep in mind conditions like acute pancreatitis and gastric cancer, those can actually often be managed with post-pyloric feeding jejunostomies, totally bypassing the disease zone. Question 72. Which of the following will be the initial sign of hypervolemia or fluid overload in a patient on total parenteral nutrition? A. Confusion. B. Tachycardia. C. Weight gain. D. Dyspnea. Or E. Tachypnea. It's C. Weight gain. Physiologically, you simply cannot gain true lean body mass faster than about 0.2 to 0.5 kilograms per day. So any sudden weight gain exceeding 1 kilogram within a 24-hour window, that's your definitive, reliable, early warning sign of acute fluid retention. If you miss this early sign, the clinical progression leads straight into pulmonary congestion, presenting sequentially as tachycardia, tachypnea, and eventually dyspnea.
Okay, let's shift to sodium. Question 65. All of the following are causes of hyponatremia except A. Diabetes insipidus, B. Syndrome of inappropriate ADH secretion, C. Hypothyroidism, D. Nephrotic syndrome, or E. None of the above.
The exception here is A. Diabetes insipidus. Why? Well, because the central deficiency or peripheral resistance to ADH leads to massive polyuria. You lose a ton of hypotonic free water. And losing all that free water actually concentrates the remaining blood, leaving you with hypernatremia, not hyponatremia. Contrast that with the others. SIADH causes euvolemic dilutional hyponatremia. Advanced hypothyroidism triggers non-osmotic ADH release, and nephrotic syndrome causes hypervolemic dilutional hyponatremia via the renin-angiotensin-aldosterone system. Question 69. Which of the following laboratory profiles is diagnostic of syndrome of inappropriate ADH secretion, or SIADH? We have options A through E, with some pretty complex combinations of high and low plasma osmolality, urine output, and urine sodium. Take a mental second to build the exact multi-system biochemical signature for this one. All right, the diagnostic match is A. Low plasma osmolality, hyponatremia, low urine output with concentrated urine, and elevated urine sodium. It's like a giant puzzle. Inappropriate ADH forces the kidneys to just hold on to water, which drops plasma osmolality below 280 and sodium below 135. But here's the kicker. Despite this systemic dilution, the urine is highly concentrated, over 100 milliosmoles per kilogram. And urinary sodium is elevated because that expanded blood volume triggers natriuretic peptides. The core triggers for this whole cascade? Usually CNS disorders, pulmonary diseases, ectopic hormones like small cell lung carcinoma, and surprisingly, SSRIs. Let's raise the stakes with question 68. A 48-year-old male post-craniotomy on 2 liters of 5% dextrose water develops seizures and asterixis. His sodium is critically low at 111 milliequivalents per liter. Which of the following is the best treatment? A. Insulin, B. Slow infusion of 3% hypertonic saline, C. Rapid infusion of 3% hypertonic saline, D. Desmopressin, or E. Loop diuretic. The correct life-saving treatment is B. A slow infusion of 3% hypertonic saline until those neurologic symptoms improve. Guys, this is a massive medical emergency. That hypotonic 5% dextrose worsened his post-op SIADH, causing acute cerebral edema, which is what's driving those seizures. The 3% saline literally draws fluid right out of the swollen brain cells. But, and this is absolutely crucial, beware the osmotic demyelination danger. If you rapidly infuse it to correct the sodium too fast, like in option C, you risk central pontine myelinolysis. That is an irreversible, locked-in syndrome. We absolutely must correct this slowly. Keeping the momentum going with question 71, an elderly male underwent a transurethral resection of the prostate and developed seizures post-operatively. What is the most likely cause? A. Hyponatremia, B. Hypernatremia, C. Hypokalemia, D. Hypotension, or E. Hyperkalemia. The culprit is A. Hyponatremia. This is the infamous TERP syndrome. During a conventional monopolar procedure, surgeons use large volumes of hypotonic irrigating solution, typically 1% glycine. If the prostatic venous sinuses are breached during the resection, this fluid can enter the systemic circulation incredibly fast.
This sudden absorption dilates the extracellular compartment, causing severe dilutional hyponatremia, cerebral edema, and eventually seizures. How do we prevent this? Use modern bipolar resectoscopes with normal saline, limit the surgery time to strictly under 60 minutes, and keep that fluid bag low to reduce the hydrostatic pressure. And our final challenge, question 70. Which electrolyte abnormality occurs in a patient having gastric outlet obstruction, leading to prolonged vomiting? Options A through D detail some incredibly complex acid-base and electrolyte shifts. Can you decipher the exact metabolic fallout here?
The answer is D. Hyponatremic, hypokalemic, hypochloremic metabolic alkalosis with paradoxical aciduria. It's a mouthful, but the physiology is brilliant. Prolonged vomiting means losing stomach fluid that's rich in hydrochloric acid and potassium, which gives you a profound systemic alkalosis. But the patient is also severely volume depleted from all that fluid loss. Now, the kidneys are forced to make a choice, and they will always prioritize saving volume over balancing pH. Aldosterone ramps up, forcing sodium and water reabsorption. But because chloride is totally depleted, sodium has to be reabsorbed alongside bicarbonate, while hydrogen and potassium are actively dumped into the urine. The mind-blowing result? The kidneys excrete an acidic urine despite a massive systemic alkalosis. It really makes you think, doesn't it? If we just manage isolated lab numbers without grasping this intricate fluid physics reality, we could literally cost a patient their life.